Welcome. My name is Preston Davis, and I'm going to be reviewing the first couple of modules that you've seen so far, specifically Introduction to Pharmacy and Chapter 3, DEA Scheduling and Dosage Forms. I hope that you're enjoying the course so far. Remember that if you have any questions about the course or this webinar today, please contact Samantha at the email address located at the top of your course page. So without further ado, let's go ahead and get into exactly what we're going to be covering today. In Chapter 2, we're going to be going back over the parts of Medicare, the different types of pharmacies, roles within a pharmacy, how there is a major difference between a pharmacist and a technician, what a technician can do and what a pharmacist is responsible for. Within Chapter 3, we're going to be talking about different release characteristics, ophthalmic versus otic, medication schedules, and a little bit more information regarding the different parts of a prescription. That's the order that we're going in, so if there's something that you need more information on specifically, you can just fast forward, keeping those things in mind. So first, we're going to cover the parts of Medicare. This is the slide that you had in Chapter 2. Medicare Part A and F, you really don't have much, you don't see very often in the pharmacy, I should say. Medicare Part B, as in boy, is going to cover a lot of diabetic supplies, as well as, crutches, wheelchairs, things like that. So you will see Medicare Part B. The Medicare Part A and B card is the red, white, and blue card. It's going to have the patient's social security number on it, and that's about it. We can bill that card for Medicare Part B expenses, specifically diabetic supplies. Certain pharmacies also sell wheelchairs and crutches. And certain pharmacies have the ability to bill Medicare in that way. It should be pointed out, though, that most pharmacies cannot. Medicare, let's skip Part D and go straight to Part D as in dog. Medicare Part D covers prescription medications. You're always going to see a Medicare Rx statement. That is to say, somewhere on the front of the card it'll say Medicare Rx. Medicare Part D is what covers all prescription medications for those individuals that are on Medicare. To quickly recap, Medicare coverage is for those people above 65 years of age or people with a long-term disability. So Medicare Part C and more infrequent Medicare Part F basically is an additional coverage to all the other forms of Medicare, meaning somebody might present you with a Medicare Part C card, which is their supplemental Medicare policy, and that's actually what you would bill. So again, to recap, you're going to see a Medicare Part D card the most often. That's D as in dog. And that's what you're going to use to bill the vast majority of prescriptions that come into the pharmacy. Occasionally you'll see a Medicare Part B for those people that would like to pick up their diabetic supplies, and somewhat more infrequently you'll see the Medicare Part C as in cat, and that can be used on diabetic supplies, any prescription medication, and even durable medical equipment, as we've discussed. Alright, so that's pretty much all you need to know about Medicare. Perhaps in addition, it is good to keep in mind that Medicare is a federally funded program. Alright, so moving right along to the different types of pharmacies that can bill claims to pharmacy benefit manager. There are two main types, retail and hospital, but there's a number of other ones as well. So sort of hybrid pharmacies, if you will. Mail order pharmacies are considered a retail pharmacy, but they don't really have a retail setting. So you can fill your retail drugs there, but it's really important to keep in mind that these pharmacies are closed door. They don't have any front of store. They don't have a point of sale. Everything is handled over the phone. So if you receive mail order prescriptions, of course, you'd be utilizing a mail order pharmacy. A lot of times, these mail order pharmacies are in cahoots or affiliated with pharmacy benefit managers. So, like Express Scripts and Medco and Caremark all have their own mail order pharmacies. It's a way to reduce costs for the pharmacy benefit manager. Oftentimes, the benefit to the patient is that they can receive a 90-day supply for maybe the price of a 2-month supply. A little bit more accessible to the patient are chain pharmacies, supermarket pharmacies, what's known as mass merchandiser pharmacies like Walmart and Target. Independent pharmacies aren't as prevalent as they used to be, but they do still exist, so-called mom and pop pharmacies. Now, something that's actually on the rise are specialty pharmacies. So the best way of describing a specialty pharmacy is a pharmacy that provides medications that aren't typically available at what you would find at like a CVS or a Target or a Walmart or a Walgreens. These are pharmacies that might provide radiopharmaceuticals in the case of nuclear pharmacies, infusion needs a lot of times for long-term care facilities, or to be used in conjunction with like a hospital pharmacy. And compounding pharmacies. So compounding pharmacies provide medication for patients that isn't commercially available. So a lot of compounding a lot of compounding pharmacies will provide medications for animals, so the dose is extremely small, or medications for pediatric clients, so also the dose would be extremely small. In addition, they provide, hormone replacement therapy, certain pain management needs. And compounding pharmacies do get a lot of flack. If you'd like some good reading, research New England Compounding Pharmacy. A few years back, they provided sort of tainted materials to a number of their customers, and many people died. Now, it's not right to toss everybody into that, every compounding pharmacy into that sort of negative stigma. Many compounding pharmacies provide a great a great need for those that can't find their prescriptions in a commercially available way. As I mentioned, vets, pediatrics, hormone replacement therapy for both men and women. So there is a great need for them, and because of New England Compounding Center's mistakes, they're now very regulated. But it's good to keep in mind that pharmacy technicians work in all of these different environments, and their roles are very different between them. So let's move along to the specific roles that a pharmacy technician and the different roles you would find in a pharmacy. So first we have a pharmacy manager. So a pharmacy manager is most often a pharmacist that's approved by the Board of Pharmacy. It's ultimately responsible for everything that occurs within that pharmacy. Let's say, for instance, that a Schedule II medication was found to be missing at a pharmacy. Well, the pharmacy manager is responsible for that loss. Their license is sort of on the line, I guess is the best way of saying it. Pharmacists are licensed by the Board of Pharmacy to practice pharmacy. Like I said, a pharmacy manager is a pharmacist most often, but a pharmacist is not necessarily a pharmacy manager. So you could have staff pharmacists, that is pharmacists that basically go in and punch the time clock. They do have a responsibility for anything that they dispense. However, the pharmacy manager is still ultimately responsible for everything regarding that pharmacy's dispensing in any given period of time, not just in the time that they are there at the store. Now, so a pharmacy technician assists the pharmacist and pharmacy manager with the filling and processing of claims. They do just about everything in the pharmacy. We'll get into the differentiation between a pharmacist and pharmacy technician in a minute. A pharmacy cashier isn't in every pharmacy. So many states, like Texas, for instance, has a pharmacy clerk role. They can basically only maybe answer the phones. They're very limited in the questions that they can answer, and they can check people out. Pretty much, that's pretty much it. But some high volume pharmacies actually have a need for somebody working, maybe 40 hours, or even a couple people call it 80 hours a week, that are only pharmacy cashiers. It's advantageous for a pharmacy to hire a pharmacy cashier because, they wouldn't have to pay the higher salary to a technician or even a pharmacist. All right, so a pharmacist and a technician are very different. You can look at it like a pharmacy technician is sort of the workhorse and the pharmacist has the license. That's a good way of looking at it, I feel like. So a pharmacy technician cannot check prescriptions, and a pharmacy technician, cannot do anything that requires sort of the educational acumen of a pharmacist. So it would be improper for a technician to do anything that a pharmacist could not check. Meaning, if a doctor called in a new order, the technician could not take that new order because the pharmacist would have no way of checking that the pharmacy technician wrote down everything correctly. Likewise, a transfer from a different store, a pharmacist would have to take care of that. Counseling is something that these pharmacists went to school for 4 years to learn how to do. So a pharmacist would have to take care of that. Any pharmacy error ultimately can go against the pharmacist's license. So, in the big scheme of things, pharmacists are responsible for all of the technician's actions. So keep that in mind when you might face questions as to, can a technician? Just think to yourself, would it be reasonable for the pharmacist to be able to oversee that? So some things technicians can do, and the list is almost endless. But a technician can fill prescriptions because ultimately the pharmacist can check that. The technician can enter new orders. The technician can even take refill authorization requests if there's no change to the prescription, because ultimately the nurse is on the phone and says, I'd like to authorize 4 additional refills for this prescription. That's a very straightforward, very simple thing a technician could take. Although the pharmacist can't really check it, it's a number. It's a single number, and there's only so many mistakes that can happen. I suppose that's the reasoning behind that. A technician can show a patient where something is on the front of the store, but can't counsel them as far as, it makes the most sense for you to take this medication to the exclusion of all others for your ailment. That's called counseling, and only pharmacists are allowed to counsel patients. So like I said, just try to keep that in mind when you're thinking about what a technician can and cannot do. If you have any specific questions about that, email Samantha. She'll be happy to help. All right, so that's pretty much the end of what we're going to discuss with Chapter 2. We're going to move on to Chapter 3 now, and we're going to start with the release characteristics. So many tablets and capsules are available in different types of releases. So, you might have a release that is an extended release. So like oxycodone comes as an extended release. So it's used for like chronic pain management, pain that occurs over, seemingly endless periods of time. Whereas oxycodone IR, immediate release, is used to treat acute pain, the pain that occurs, it's sharp pain that occurs over short periods of time. So these are different drugs. They have the same active ingredient, but their release is different. And because their release is different, it would be an error to dispense the extended release instead of the immediate release. I've tried to simplify things on this slide by lumping all of the extended release types into one category. So, CR, ER, XR, LA, DR, SA, all of those are extended release categories. So, I think that it's important to just keep in your mind that immediate release is different than all of those. And it's the easiest way to remember these things. And believe it or not, diltiazem is one of the few examples of this. It's possible that you can have an ER and an XR in the same with the same active ingredient. So diltiazem ER is different than diltiazem XR. It's sort of unscrupulous, so it's sort of improper how drug companies have done this. What they'll do is they'll release a drug, and it will be an immediate release drug. We'll use Fosamax as an example for this. Alendronate is its generic. So Fosamax originally came out as an immediate release. Once the patent started to run out, they released a 3-day Fosamax. So you'd only have to take the tablet once every 3 days. That was sort of an extended release. And then once that patent ran out, or approached running out, so to speak, they released a 7-day Fosamax. From the drug company's point of view, this was a way to make more money. I mean, there's really no other way of putting it. By providing a product that somebody would only have to take once a week rather than every day, obviously that is an advantage for the patient. It's just sort of hard for me to believe they didn't have that sort of release ability at the very beginning, and things surely worked out really well for them, being able to release 3 brand name products successively rather than just the once a week version from the beginning. They made a lot more money that way. All right. Sorry. Ophthalmic versus otic. So this is something that will come up on the PTCB exam because so many errors can be made in this way. Most products are only available as an ophthalmic dose or as an otic dose. Cipro is one of the few exceptions. And it's also one of the things that, or one of the errors that's consistently made in the pharmacy. So an otic preparation can only be used in the ear. It's non-sterile, meaning it could have particulates in it, and that would be acceptable. An ophthalmic preparation is intended for the eye. It is sterile. You can use a sterile preparation in the ear, but you cannot use a non-sterile preparation in the eye. Meaning, it's possible to use an ophthalmic preparation in the ear, but it's not possible to use an otic preparation in the eye. I just want to nail this point home. I know the slide, describes this, very seemingly, it's white and black, but I just want to nail this point home because this is almost a guaranteed question on the national exam. All right, so what we're going to talk about now are the parts to a prescription. Within the chapter, I think chapter 3, I'm sure chapter 3, you can mouse over these different areas, these sort of blue highlighted areas for more information, but I want to kind of go through them one by one here. So at the very top, you have James McKinney. In that case, that's our doctor's name. You want to make sure that matches the signature at the bottom. You'll have information regarding the practice there. A lot of times the telephone number is very useful to you in case they're missing a specific part of the prescription. In this case, it actually has the DEA number pre-printed. A lot of them do. Then you'll have the patient's name. You'll have the date written on the prescription. In this case, this one's very expired. You'll have the medication name, the strength, the dosage form, the dose, the frequency, the quantity, as I mentioned before, the signature, refills, and the DAW. So I'm going to go through a couple of them that might not always be there, and I'll explain why. So each prescription, you must be able to determine the day supply and the quantity. So sometimes they'll just give you the quantity. Other times they'll just give you the day supply. But as long as you can take the dose and the frequency and utilize either the day supply or the quantity, that's sufficient. So it's possible that this prescription could say one QD for 30 days. You would know that that's once a day for 30 days, and you would know to dispense 30 tablets. That's fine. That's appropriate. In this case, it doesn't tell you how many days, but if they're taking one tablet daily and there's 30 tablets, it will last 30 days. So that's fine. You don't need the day supply to be expressly written. The other thing that there's two other things that might not be represented. So here, you notice that there's no real way to determine how many refills they have. Well, if you have refills pre-printed like this one does, and there's no circle around the number of refills that they're after, then you can assume that no refills are authorized on this prescription. So they just simply have the only fill of the prescription with no refills. DAW is another one that is often unchecked. So if DAW, dispense as written, is not checked, you can dispense the generic equivalent of that product without any problem. Now, if the patient comes in, if the DAW is unchecked and the patient comes in and says, hey, you know what, I want brand name on this, that's fine. It's considered a DAW 2. You just dispense the brand name per the patient's request. Now, often insurance companies won't pay for the brand name because the patient wanted it, but that is the patient's right to have that dispensed. It might also be their right to pay a huge premium for that. Less often nowadays, you'll see DAW checked, or DAW 1, or dispenses written, or brand name medically necessary. All of those would indicate, a DAW 1, and you submit that to the pharmacy benefit manager. Even then, it's not guaranteed that the pharmacy benefit manager will cover the brand name product if a generic is available. All right, the last thing we're going to talk about are medication schedules. So the first schedule is a Schedule 1 drug. So a Schedule 1 drug is illegal. It's, marijuana, heroin, LSD, ecstasy. In a pharmacy, we don't deal with these things. But it's important to know that, for a matter of completion, that Schedule 1 drug is an illegal drug. Schedule 2 drugs are typically highly addictive pain medications, attention deficit disorder or attention deficit hyperactivity disorder medications, or addiction management medications, like oxycodone, hydrocodone, morphine, hydromorphone, buprenorphine. They must be written or electronically prescribed. In a long-term care setting, they can be phoned and in some states faxed as long as a written prescription follows within 72 hours. The prescription must have the prescriber's DEA and the patient's address written or typed on the prescription itself. That's a requirement from the DEA. So Schedule 2s are sort of because they're the most risky medications that a pharmacy dispenses, they are the most highly regulated. Schedule 3s, 4s, and 5s all have the same requirements. They're either moderate pain medications, anxiety medications, or products that happen to contain a substance that could be abused, but might not be used for pain. So a good example of that would be the guaifenesin with codeine. So guaifenesin with codeine is actually used for cough, but codeine is also by itself or with Tylenol used for pain. You might have heard of Tylenol number 3. That's just acetaminophen with codeine. So while acetaminophen with codeine is a higher schedule medication, it's a Schedule 3, guaifenesin with codeine is a Schedule 5. So it has a lot to do with the intended use of the medication as the schedule. However, because it contains codeine, it's still scheduled. So a medication used for cough could technically be scheduled, like in this instance. These are considered controlled prescriptions, 3s, 4s, and 5s. Schedule 2s are considered narcotic prescriptions. They can be written, phoned, faxed, or electronically prescribed, much like the next category that we're going to talk about. Like narcotic prescriptions, these must have the prescriber's DEA and patient's address on the face of the prescription. So other legend drugs, so these are non-scheduled legend drugs or non-scheduled prescription drugs. It's every other medication that requires a prescription. There's a list of different examples here. Just like Schedule 3 through 5, they can be written, phoned, faxed, or electronically prescribed. The prescription does not require the prescriber's DEA nor the patient's address to be written or typed on the face of the prescription. So that's a recap of Chapter 2 and Chapter 3. I hope that we might have cleared up any inconsistencies that you had. And as I've mentioned a couple times during this, if you have any questions, email your course instructor. That email address is at the top of your course page. Her name is Samantha, and she's happy to help. Like I said, I hope this helped out.